This CNBC Africa special is brought to you by the Gauteng Department of Health.
Hello and a warm welcome to the CNBC Africa special. I'm Gugulethu, Cele. The Gauteng Provincial Department of Health budget for this year is set at 34.2 billion rand. How will it be used to revive the healthcare sector in the province? Well, here to discuss that with me and the issues around the healthcare strategy to hopefully uplift the healthcare economy in the province of Gauteng is Gauteng Health Department MEC Qedani Mahlangu. Also with us, though, is our wonderful studio audience of key players in the healthcare sector, and a little bit later we'll be taking questions from the audience. But MEC, we'd like to get into the numbers firstly. We hear of this large sum being the budget that sits at 34.2 billion rand. If we take a look at a recent Deloitte survey for 2014 rather, which looked at the South African healthcare economy, it does mention that the spend on the healthcare sector is expected to increase by almost 8.8% between 2013 to 2017. Coming back to the numbers though, a large chunk of it, 33% to be precise, is actually going towards community healthcare service centers. But before we get your view on these community development healthcare sectors, I'd actually like to get a quick fire view from you as to what you think our rating is on a scale of 1 to 10, 1 being the lowest, 10 being the best, as to how the Gauteng healthcare service actually fares and where you'd like to see it go.
I think on the scale of 1 to 10, I'd like to say we're standing at about 6.5 or so. A reason being, I think what continues to put us on a negative light in the public is the attitude of some of our staff members to patients. And every single day I'm on radio explaining and apologizing and taking responsibility of that. And I think if we're to address that, it will go a long way to change the perceptions about and improve the experience of our patients when they visit each and every one of us, our facilities, every single day.
It almost sounds as though it starts back with people and people on the ground. Let's go back to the community development centers where you were hoping to boost further investment into the community healthcare services that you provide. And more importantly, how you're hoping that this will address both the overburden disease that we have in South Africa of non-communicable and communicable diseases.
Of the 34 billion budget we've been allocated by Treasury, 10 billion of it is going towards primary healthcare re-engineering. Included in that is about intensifying and increasing and recruiting the numbers of community healthcare workers, as the NDP envisages that South Africa should recruit, train and deploy 700,000 community healthcare workers by 2030. So Gauteng, we've got about 8,900 as we speak. So if we're to intensify their training and empower them such that as they are based in communities, there must be a bridge between a community and the clinic, that will go a long way in just improving the levels of awareness in our society about, first of all, what really bothers me every day is the levels of women who are pregnant who do not visit health facilities before they're 20 weeks pregnant. Secondly, is to also detect the number of people who are living or who also have TB but they are not aware. And thirdly, also people who are HIV positive, for whatever reason they're sitting at home and all of that, and they're not knowing their status. And of course, the number of people, of children who are supposed to be vaccinated and they're not vaccinated because they do not go, their parents don't take them to health facilities. So if we're to get, and of course, levels of malnutrition and poverty in Gauteng should not be underestimated. So as community health workers do this work in the community, house by house, we develop a family file and an individual file with that community. We'll be able then to enable clinics to have a sense of what is happening in a profile in that community so they can do easily a follow-up. Nurses go out to families and talking to them, as well as lessening the number of people who come to health facilities and simply wait. For an example, in Shawelo, people who come to the community practice that is within the Shawelo clinic do not come there without appointment. They come there with appointment because community health workers work with them as well as linking with the doctors. Of importance, linked to that work, is the healthy lifestyle activities which the community health workers are involved. Every single morning in Shawelo, this group of young people go out there and assist community members to exercise. Some people were meant to do an operation of whatever nature at Krisani Paragwanat, but because of the consistent exercises and the correctness of the exercises, some of them have been able to avoid operations. So investing this 10 billion rand into community outreach as well as getting our clinics to work, staffing issues improve, staffing levels issues being improved, ensuring that medicines are available at any given point in time, increasing the size of our health facilities is also very important. So this money is meant to go to those key services, and I think if we get this right, we stand a better chance of just of winning the battle against people waiting long in our queues, and also preventing women not being seen before that 20 weeks, and that is remain a worry to me.
Let me see, let's go into those women where we know that maternal health care is a huge priority. It's an issue that is faced across the continent and across the globe. If you go back to the Millennium Development Goals, number 5 in particular, to improve maternal health care across the globe. If we come back to the South African context of things, and more importantly in Gauteng, I understand as well that this is a key priority given the development of maternal homes. From a national perspective, we've recently seen the Minister of Health, Dr. Aaron Motsoaledi, also launching the Mom Connect app. On a local and national level, are we going to see the bridging of this potential divide? Basically, national policies being implemented on a local level through the development of these maternal health care facilities.
Remember, firstly, Mom Connect is a software application which all pregnant women who go to all their health facilities can report the attitude of a nurse, and also we send messages through the National Department of Health about to pregnant women about every information that they need to know, why they must take this medication that they must take, why they're supposed to go to clinics, when they're supposed to go to, why women who are HIV positive are supposed to take the prevention to from mother to child transmission. All of that information is transmitted to them to make them more aware, but also to deal with the attitude of our nurses. That information is compiled by National Department of Health back into provinces so that we can implement, deal with the attitude of the nurses, and also deal with the instances where a woman would have been sent back, and then all of that, so that the information is meant also to come back to provinces, and we're implementing those things and also making intervention in those areas. Secondly, the maternal homes, I'm told they used to be available in South Africa many years ago. I'm not sure why we discarded them, but maternal homes, it's not a hospital, it's not a clinic, it's a home where women are looked after in terms of their dietary needs and then all of that. But someone who's got healthcare, who's qualified, largely we're going to work with the midwiferys, particularly the retired nurses, to help us to support this thing. We've seen it in Cuba, of course. They've got the highest number of doctors, so that the maternal homes in Cuba are run by obstetrics and gynecologists. So what we're going to do here, some of them, because we've got additional space in hospital which currently are not being utilized. I think the first one we're going to launch it at the Yusuf Dadwi in Mukhale City. It's going to be linked to the hospital. We're targeting the youngest mothers, the teenage mothers who are pregnant, because there's a lot of complication around that. Women who are HIV positive, there's normally a lot of complication around that. Women who are overweight, women who are underweight, and all of that. So dealing with just managing those women, set of women, they pose a particular risk. And we've seen with the maternal death study that National Department conducts from time to time, it shows what are the causes of maternal death at any given point in time. Overbleeding, that's called hemorrhage, and then all of that. So if we're to prevent the risk of someone who's HIV positive, prevent and avoid all the risks that are associated with the pregnancy whilst the mother is pregnant, we guarantee by the time the day of delivery happens, those risks will be eliminated. The mother will give a birth to a healthy baby, and also there'll be no risk associated, linked to her, because those will be eliminated. That's the role of the maternal homes. We're losing too many women due to overbleeding when a woman is identified, is reported from home to between the home and the health facility, and the home, the first health facility, maybe it's a clinic or CHC to the hospital, and we want to eliminate those for the better. We cannot, as society as advanced as ours, we cannot afford to lose women simply because they are pregnant, because pregnancy does not mean that you are ill. It simply means that you have a child you're carrying, and you've got an additional life that you must bring on this planet. Therefore, what you eat, how you conduct yourself during that pregnancy, including avoiding consumption of alcohol, including avoiding consumption of any drug related, because whatever you do as a mother also affects the baby that you're carrying.
I'm happy that we can tell how passionate you are by this. It's just we'll get the audience's views on it in the next half an hour. But if we explore as well the role of maternal health care and how you're prioritizing this quite seriously, if we look at the rollout of new ambulances that you're looking to procure, I understand of the 160, yes, 40 will be allocated to maternal health care? Yes.
From 2009, when we started as a MEC for Health, then one of the doctors suggested that we should have obstetric ambulances, which means it's an ambulance dedicated to transport a pregnant woman. If she needs to deliver on her way to hospital in that ambulance, the ambulance is structured in a manner that, or the features in the ambulance are structured in a manner that enables a woman to give birth whilst they are en route to a health facility. So we've procured, and I think over a period of time, as we speak, by the time we finalize the procurement of the 40 ambulances, would have not less than 100 in the province of obstetric ambulances. Why are we doing this? We are going to place these ambulances in the community healthcare centers. Why community healthcare centers? We've got 35 of them. So each community healthcare center will have an obstetric ambulance. The reason is these are health facilities located in the biggest part of our townships, which help women to give birth with non-complicated pregnancies. But in case a woman complicates during delivery, the obstetric ambulance is available on site to transport her immediately to the bigger hospital, which largely will be a district hospital, and if indeed it requires a regional hospital, they'll be transported there. So you eliminate the waiting time and all the other things. And of course, one thing that why we're doing this, and I often say to my colleagues in the department that we do not have a second chance to correct our mistake. If we do whatever mistake we do at the first instance, it may be catastrophic. So if we're able to save the life of a mother and the baby with a few seconds of her getting an ambulance, being there and transporting the mother to the nearest health facility to give birth to a healthy baby, that's what we need to do. That's why they are all located in the community healthcare centers for ease of transportation of mothers. So we also have a planned patient transport, which is also linked to all our hospitals and all our health facilities, where patients must be referred from one area to the other, again, to make it easy for patients that your family drops you here, but this hospital may not have the competencies or the tertiary level to treat you, and would take you by transport and take you to the next facility. So that transport is available. So I'm hoping that with the work that we're doing in procuring more ambulances, will save more lives of women from dying because they're pregnant, but also will enable society to, South Africa, to deal with our birth statistics of just losing too many women, because we can prevent this loss of life. And I think it's important that we do everything and anything to prevent this, including providing these ambulances. And of course, we're also training additional midwives, and in the training we encourage a lot of young nurses to take interest in becoming midwives, and that is working very well so far.
MEC, I'd like us to take 2 steps back to the issue of the ambulances, because unfortunately in the province of Gauteng we are still running short. For the population of 12 million people, we should have at least, what, 1,200 ambulances. And isn't this the part where you need to work with other stakeholders in the industry to hopefully bridge this divide? Are there plans to implement potential public-private partnerships in that regard, as well as you say, the ongoing treatment of patients, as well as in the private sector facilities, hopefully?
Firstly, by law, the National Health Act, as we speak, there shouldn't be no person who is not picked up by an ambulance and taken to any health facilities, irrespective of whether we can afford or not. If an ambulance picked me up in Alexandra, I do not have my medical aid. Instead of taking me to the Alexandra Clinic or to Edenvale Hospital, the nearest hospital is Mediclinic here, they should bring him here. But the tendency has been what I'm told is called wallet biopsy. They check whether you've got a medical aid in your pocket. If not, they leave it at. But we're working to improve those. We've had, my team has had a meeting with we've had a meeting with all the private healthcare providers, all of the Mediclinic, Health and Netcare, and all of them. And we've said to them, can we work together? Because it doesn't make sense that we have, I think, about 5 or 6 private ambulance providers in the province, including municipalities ourselves, all the private healthcare providers, big and small. When there's an accident, 5 ambulances respond. And in the townships, no one responds. They take 2 hours, 3 hours. So we've said to them we must collaborate. Currently, we're working well on disaster issues, disaster-related. Recently, there was the last train accident which took place. I saw them live at Charlotte. I was at Charlotte with the team. I saw the Netcare ambulances bringing patients there. I saw the government ambulances bringing patients there and all of that. So the point is, indeed, if we have to resort into legislation to force all of us to work together, we will do that. But
having
at the
said
moment,
that, though, MEC, would the private sector players, though, need some kind of incentives to get them to participate?
There's no reason for any incentives, because remember, health is not a commodity. I think we should start there. Health is not a commodity. It's a service that must be provided to people. If I'm hurt in an accident, it doesn't matter whether I have money or not. What must be primary is that I must be taken to the next facility and save my life, and then the rest can follow. That's what is important. So with the ambulances, we've got 870 odd ambulances if you put private sector, the municipalities, and provincial government together. So we're buying additional 160 in this current financial year. We've already procured a system which is going to ensure that there's coordination of all of these ambulances, including tracking where our own ambulances are at any given point in time, because that is important. And in doing so, also say the discussion we're having with the private healthcare providers to say, if indeed you are closer to Alex, your ambulances here, whatever, shouldn't they serve Alexandra Township? Your ambulances, if you are closer to Millie Park, shouldn't you serve Mayfair and all of those areas that are closer to Deep Kloof and all of that? So that's kind of discussion we're having with the private healthcare providers. It's important for South Africa. As we prepare for NHI, private healthcare, we're going to ensure that citizens get services, the basic cover across the board, irrespective of which health facility you go to. If I want to top up, yes, indeed, I'll get a higher package. But everybody must get a standard coverage, which we call the universal access to health services. So that is important. So by the end of this year, we also have, when we buy these new ambulances, we're going to have the new ambulances branded in the color that that is being finalized in terms of the NHI. It's important to coordinate, to avoid duplication, to maximize and optimize the current usage of our resources, because the ambulance are the essential services. If we were to respond to reduce the time that we respond in saving, the P1 is someone who's a life and death. If we don't respond in 15 minutes, we may lose that patient. So if we're to improve this coordination, we'll save many lives, as well as improving coordination, making sure that the P2, P3, but also it's important to educate our citizens. That education is important. Why? Some people call for an ambulance when they don't have money to get a taxi to go to a clinic. Again, right? So there's many things that people have found very funny reasons to call an ambulance when they actually do not need an ambulance. Just imagine someone has been denied a major service to respond to a major accident, and we've responded to someone who says, "Askis, maneki batla hospitala nekis na chelete samai."
Translation? I did not have money for transport.
Sorry, I didn't have money for taxi fare or bus fare. Just take me to the hospital now that you're here. But I wasn't that sick. So to just tell people, to educate people to understand what is P1, what is P2. When you call an ambulance and say, I have a heart attack or I can't breathe, whatever, it must be genuinely because you can't breathe, not because the previous day you were drunk and you did all sorts of kind of things and you feel too paralyzed and you can't do things and say, well, I think an ambulance may be a solution, those kind of things. So.
MEC, I certainly hope we can get that message across to the people on the ground. But coming back again to this issue of partnerships, because surely it is a multi-stakeholder approach, especially when it comes to the private sector. And maybe if we can go into the NHI, which you alluded to quite briefly, that continued ongoing partnership, not only with your contractors, your staff, and other members of the private sector, who will enable the NHI to be a policy which can be rolled out efficiently, especially when it comes to pharmaceutical and medical supplies. We know the headlines and we know the approach that you're taking to the Stop Stock Out campaign when it comes to the delays and in delivery of medical supplies. Are you reviewing perhaps your relationship with contractors, with members of the private sector and even local companies to ensure that there's a timely supply, efficient supply, and one that's cost effective?
I mean, the first thing we need to say that we are one of the biggest consumers of services in this economy. Currently, we buy virtually everything and anything from imported goods. From equipments, whether I buy Philips, Siemens, General Electric, you name them, they all come from overseas. And I remember when we were opening that spray, I said to them, but why is this equipment not coming? They said, well, MEC, it's from Germany. And okay, how is it going to take care? Well, by ship. I said, well, why don't I send you in a plane? I know you'll arrive in Frankfurt or Berlin, whatever, in 24 hours, and you'll bring the machine the next day. So why is that not possible? So what I'm saying, to surgical gloves, to condoms, to medicines, none of those things are made in South Africa. So what we are trying to do, and we're working very systematically. Recently, I visited a factory in Midvaal, which I didn't know that it exists, in Merton. I've been told all along, we've been buying Chinese bandages. People who go to China buy us bandages, and hospital CEOs complain, and clinic doctors complain, and nurses that these bandages are not of good quality, this and that, because not that everything that's bought in China is not good, but people buy the cheapest so that they can make the biggest margins when they come in. And that's what is wrong about what is happening. So now that we've seen the factory, I took some clinicians there and I said, look at this factory, look at what is happening. These people are producing these things in here, and we spend 126 million on bandages and dressings alone as one department. So if we were to just support the production of the bandages and dressings from that factory, it's going to go a long way. Secondly, we buy we don't have an API plant in South Africa, and I know there's Getlapili and all of those things, but we've got to really drive the agenda of having the productive capacity in South Africa to produce this thing. We're continuously supporting India at our expense, at our expense of our economy. We no longer have a penicillin plant. That's why we had the kind of difficulties that we have. So what we are doing really in a small scale as a province, whatever is being procured or manufactured locally, we go to those factories, we look at it and we buy it. And I know that different companies, whether it be Aspen or be it Adcock or be whatever, they've got their footprints in the province in producing different things and all of that. And our interest really is to make sure that whatever we buy, firstly, we must satisfy ourselves that the South African market can satisfy our needs. If indeed we must look outside, that's what we must look into. Because again, if we continue to supply other economies, we are killing our own economy. We're not creating jobs, yet we have got a huge number of young people who are unemployed. Secondly, one of the things that we need to be looking into is to really try and support and eliminate your middleman in the process. For instance, we buy bread currently from what you call distributors. We don't buy bread from someone big, whatever, Albany, whatever the case is. So instead of rather than me buying through the distributor, let me just buy it from a township person who's got a decent bakery. I know that I'm feeding not only his or her family, but I'm feeding many mouths just by buying there. But of course, we're supporting them to have good quality infrastructure, to make sure that their abattoirs or farmers good quality standards and all of that.
What's stopping us, though, MEC, from doing that and implementing it in this financial year?
We are doing it, just at a small scale. For instance, for farmers, we cannot procure from them directly because these contracts are running till next year, including the bread. This bread middle people that dispute charge are still running till next year. So after next year, July, I think June, July, those contracts will come to an end. We'll be able to buy from them. But an important point, now we are supporting them to get all the regulatory compliance and all of that. And one of the things we are interested in with this budget that we have is to look at getting the Department of Health's infrastructure out of reliance from Eskom electricity. We cannot have a hospital going in the dark. Yes, we've got a number of, all our hospitals have got generators, more than one, but we should be in a position to use the sun much more constructively to be able to generate energy to power our health facilities. And we are resolute to make sure that that happens, and it's got to happen and happen very fast. So those are the things that we want to use our ability to buy and procure to support industries that are locally operating in order to support our economy, but also to have self-reliance. This thing of getting everything overseas doesn't work. And just lastly to say that I think the important thing about the NHI is that I've looked at the NHS in the UK. It's been implemented for 67 years. It's not a perfect system, but it's worked, and they've been improving it over the years, over time. So the NHI we are roll out in Tshwane. Yes, there's a good semblance of us meeting the cost standards as determined by the National Department of Health. Different facilities across the province are at varying degrees. And I mean, we are very proud that Steve Biko is the only academic hospital in South Africa that has met the 100% compliance of the extreme cost standards in the province. And I think it's something that we should be very proud about. And on top of that, all our health facilities now will also, because the NHI, the Ideal Clinic is part of the NHI. Remember, the president was talking about the big fast results last week about the Ideal Clinic, that the clinic must see people, as long as a patient is in the clinic must not close, open in time, all the supplies of goods and services must be there. The question you ask, how do we work with the other people? As long as we are working the way we are working as a provincial government, we've taken a decision that we will partner with each and every stakeholder to make, as long as it helps us to improve our services. Whether we're working with stock out to help us to understand what our level of stock, because we don't have systems currently to tell us that, we are going to partner with them as long as they don't have any political ulterior intention. The intention is about improving the services to the citizens for the better, and that's our outlook. Working with the private sector companies, whether pharmaceutical companies, medical equipment companies, all of them across the board, our intention, and we continue to talk to them and to engage with them, because the guarantee of supply of anything that we procure is very important. But also for them, they need to have projections of what we need. And again, the continuous engagement with them is very important for us.
MEC, I can tell we've just touched the tip of the iceberg. We're going to take a short break, but when we come back, we'll address some of the questions that will be raised from our audience. Do stay with us. Welcome back. We're still talking to the MEC of Health in the province of Gauteng, MEC Qedani Mahlangu. Now, we're taking this conversation further by taking questions and comments from our floor, which is made up by audience members who are stakeholders in the healthcare fraternity. We've got our first question. If you could please introduce yourself and pose your question to the MEC, sir.
Thank you. My name is Stavros Nicola, and I'm from Aspen Pharmacare, and also here as chairman of Pharmaceuticals Manufactured in South Africa, the local Pharmaceutical Trade Association. I firstly need to commend the MEC. She's always been a strong proponent of supporting local industry, supporting local manufacture. And my question to her is, the pharmaceutical trade deficit, despite all the hype around local procurement, has grown year on year. And in the last decade, India never featured in the top 10 exporters of pharmaceuticals to South Africa. They're now prominently in position 1. So a lot of that trade deficit has resulted because of generics that have been imported into the country, primarily out of India. When this issue is raised with the national authorities, there is some sympathy towards local production. However, there's a lot of red tape and bureaucracy in the way procurement processes are implemented, specifically regulations to the Preferential Procurement Framework Act. My appeal, more than my question to the MEC, is how can she take her passion for local manufacture back up to national, make sure that we start bridging that trade deficit that's so prominent in the pharmaceutical sector. Thanks.
Thank you so much for your question, Mr. Nicolau. If we can move the mic this way, there's another question.
My name is Philip Marais. I represent the CSR, the Council for Scientific and Industrial Research. My question relates to a comment you made earlier based on a question from our host relating to incentivizing the public sector to support the Gauteng Department of Health and also the National Department of Health in their mandate to provide quality healthcare services. Unfortunately, you made the comment to say that it need not be an incentive, that the saving of lives has to be an incentive by itself. But unfortunately, I don't think that the private sector in that case might necessarily agree to the full extent of that comment. My question is, are there any explicit budgetary allocations or plans for the Gauteng Department of Health to support or to incentivize the public sector to partake in whatever different capacities, whether it be rebranding the value of primary healthcare to the public, and whatever else capacity they can support the Gauteng department to deliver their mandate for healthcare? Thank you.
Mr. Marais, thank you so much for your question. If we can move the mic to the lady at the back.
My name is Siobhan Brooks. I represent Shonequip, which is a local manufacturer of pediatric wheelchairs and assistive devices. Is there any way in which we can speed up the process in terms of payment for the devices? In many of our hospitals and clinics, we see that if people order devices for children with disabilities, they often have to wait up to 2 years to get the devices in many of our facilities, in a place that I've worked previously as well. Is there any way to speed that up or ensure that children get what they need when they need it? Thank you.
Thank you so much for your question, Ms. Brooks, Mr. Marais, and Mr. Nicolau. MEC, I take it you can almost combine all of those questions and maybe address them in a combined answer, where they all quite focus on local procurement. Let's start off with Mr. Nicolau's ambitions for you to take back your passion back to a national level where local procurement is something that is prioritized.
Thank you very much for all the good questions. It's just to say that I fully agree with what has been said by Mr. Nicolau on the issues around the deficit, because if our trade deficit continues to be on the negative, we're not doing well in terms of our economy. It means we're buying goods and we're supporting other economies literally at our expense, and then I think that's why I can simply put it in a simple English. So we have to be selfish as South Africans. And my understanding is that last night we spent the whole about 5 hours at the IDC with the Premier and the Minister of Economic Development, Minister Patel. We were talking to black industrialists, and some of them raised these issues. And I know that the Premier said we should, and we've been talking to him, myself and him and MEC Maile, we've been having a conversation on what is it that we can do as a province to work with national government to make sure that the issues of the pharmaceutical industry are taken in all seriousness, because it doesn't make sense for me, from where I'm sitting, that we'll buy generics from India when we've got, I think some of, one of the biggest South African companies, whatever generics company is in South Africa, operating all over the world. Why can't we support our own local companies? Probably there's many others outside of the big players who are in the generics industry. But not only that, it should make sense for us to have all the big, and I know few pharmaceutical companies that by name, whether it's Adcock or Aspen or whatever, who have their footprints in terms of industrial capacity in South Africa, we should be able to support them without difficulties, because as I said, for me, the issue is not about grandstanding, it's about really taking a selfish interest as a country, because if we don't use all our aspects of the public sector to grow the economy, we rely solely on the private sector, and I don't think we have the interest of this country at heart. We also have to take that into account, and I think if the regulations are an issue, I know they were also discussed last night about the triple PFA, the price 80-20 vis-a-vis the 90-20, and all of that, why it is a stumbling block. So we'll look into those issues. But one thing I know for sure, that we have the support of the Premier of Gauteng to engage with the industries, to look at how best do we, of course, working with the national government across the board, to look at what can we do to drive industrialization to a point where we not only do we look at South Africa, but we look at the continent as a whole. And that's why I think working with Minister Davies as well as Minister Patel together with the Premier is important. And of course, the Department of Health is at the center of this.
So MEC, you're not committing to call Minister Motsoaledi? We were hoping you have him on speed dial, though, on a lighter note.
We're having this conversation, and I don't think that it will fall on deaf ear. The minister also understands why it's important for us to be doing these things. I said the Premier, the processes are led by the Premier, and he's supporting the work that we're doing. So he's working with all the ministers, including Minister Motsoaledi. As I said, he's a strategic partner in this agenda being implemented. The second thing about SSIR, I was not the incentive issue. I was mainly talking about the ambulance services, because ambulance services are emergency services in any event, whether it's provided by Netcare or Mediclinic or clinics or whatever, or by ER24. It doesn't matter. They are emergency. You need to save someone's life, and then thereafter, of course, once you stabilize them, take them to a public facility, but don't dump them on the road. Don't leave them on the road, and that's what we're dealing with, the emergency issues. How are we working with the private sector? For instance, the discussion I've had with all the private healthcare providers to say, and I know they're doing this in other jurisdictions. In the UK, most private healthcare providers see NHS patients at the public sector price. And they do volumes, not at their price, at the public sector price. And that's what we're working towards. Because, for instance, Midstream Hospital, it's somewhere in Centurion, not far from Tembisa. It's a new hospital. I was there opening it the other day. Tembisa is not far from there. Tembisa has just got shortage of ICU beds. Midstream has vacant ICU beds. Not all their beds have been activated. A patient is a patient, whether they're coming from a township, whatever. So once these regulations come into the picture, and we're discussing with the private companies to say, if indeed Tembisa is under pressure as it is, with a shortage of ICU, how do we ensure that the private colleagues come on board? But not only on an ad hoc from that point of view, but to say, we know how many ICU beds we have in the province, and ICU beds is a scarce resource. You can't have thousands of ICU beds. Private sector has, we have. How do we collaborate with the ICU beds such that when there's a need, we are able to put all of these beds together and say there's a need, which hospital has ICU bed at which facility, and we take the patients there. So that's the kind of collaboration we're talking about. Again, if we take public patients to private hospitals, we have to pay the public sector cost. That's what we're working towards. We're not saying we're not going to pay for the fees. We're going to pay it, but we're going to pay at the public sector price. And the NHS colleagues in England are helping us to look into these issues, because we are under a lot of pressure in the province. We need to do more and get our patients. We can't have patients sleeping on the floor. When the private hospital that we regulate, we give private licenses to, beds are empty, and then all of that. So we need to use all the resources optimally. And there is no opposition, in my view, from the private colleagues. I don't know, the payment issues relating to us paying what we've procured, or it's just a general issue. Let me say, on the 30-day payment, we have improve our processes. You know, the Department of Health come a long way. where we are now, I think we're paying about 90% of our service providers within 90 days, and we're putting all systems in place. There's a P-card of people we're paying 10,000 up to 500,000. We pay them instantly within 7 days or something like that. So those things were improving, and we want to ensure that our relationship with service providers is improved to a point where we adhere to the 30 days payment and all of that. And that's why we should have a constant engagement with all service providers who do services with us. And again, even where we've got difficulties for whatever reason, we should be able to have a conversation. One thing that I should really say though is that sometimes, I mean, the difficulties we've had with the supply of essential medicines in the past few weeks has had, to some extent, companies who were given contracts and had no ability to deliver. And frankly, I do not know how do we get to that point, because when a company is as close as to the medical supplies depots, less than 5 kilometers, they cannot deliver things, and month after month. So our penalty clauses must kick in and make sure that we penalize those companies, but not only penalize them, blacklist them. If they're not South African, they must be blacklisted that they'll never do work in South Africa. However, this blacklisting for me is also not helpful, because you're blacklisting a company, not the directors. They can change tomorrow and establish another company, and they continue to do that work. So, and again, we have to be very meticulous in looking at who do we blacklist. And I am advocating that not only should we blacklist the company, but blacklist the directors who submitted a tender and say, we'll supply X and Y and Z and Q. They were given that tender, and they've not supplied a single item that they said they're going to fly.
Does that also call for strict procurement measures then to be implemented by the Department of Health?
But people sometimes they falsify things. They tell you, we've got this capacity, we've got this capacity, we've got this relationship, we've got that relationship. I don't sit in procurement processes. I don't know exactly how things go, but I get a sense that sometimes companies misrepresent information, which those who are sitting and evaluating, they look at, well, this company is capable, they've done this, whatever, these volumes. And if on day one, and I think our shortcomings as government is that on day one, if a company does not deliver, we should be in a position when they've been given sufficient time to build up their stock, we should be in a position to terminate them. And we don't do it. All the time there's this and this and that. And I think our contracting processes must be strengthened and for the better.
Precisely. MEC, thanks for responding to those 3 questions. I'd like us to take further questions from the floor, but I'd also like to get some of the participation and maybe top-of-mind issues from members of the private sector. You mentioned incentives, Mr. Murray, and I'm not too sure if there's anyone else who's available here. Just to top of mind, give us an idea. We know that for private sector players, they need to ensure that they remain profitable, but at the same time, address the needs of the patient. Are there particular issues that you would like to have the government put forward on the table to not only encourage your participation in the healthcare services industry, but ensure as well that as private sector players, you do remain profitable and not run the risk of basically working closely with your best competitor, but at the same time not being able to make a return on your investment? Anyone with potential ideas? Fundamentally, we need the conversation to get going. So by the time you get to the negotiating table, right, on a national level, it's not too difficult to implement. I'm not too sure if we have responses. Mr. Murray? We'll bring the microphone to you briefly. If there are any other questions, feel free to raise your hand and we'll address them with the MEC.
Yeah, thank you. The ideas that have been proposed in the past, and these are all very, very simple ideas, mainly my experience has been in the infrastructure sector, and how to, and I know there's been past experience in triple P investments, for example, in Bloemfontein, where there's a co-investment in a public-private hospital partnership. But with the perception of going from curative to preventative healthcare, and the number of patient visits that annually are expected, according to the World Health Organization, I think are 3.5 visits per patient annually, averaged out, I guess, for pregnant women and so forth. How could we involve on a systematic level the private sector to support the development of infrastructure, particularly because we know infrastructure is a large capital expenditure, and also the maintenance thereof and how could the national and the provincial governments support the entrepreneurs on the infrastructure side to help them deliver the capacity in terms of infrastructure to support the transition to preventative health, and who's going to take the gamble? I would almost suggest to say, let's provide the infrastructure, healthcare for preventative health, as opposed to focusing still on curative health.
Thank you so much for your question, Mr. Murray. If there's another question in the audience, we'll take it briefly. Mr. Nicola? Your checks are in the mail.
Thank you. I wanted to comment more on the incentives and how those relate to local procurement. But to preface that, I just want to cite an example. I've just come back from Russia recently. I'm on something called the BRICS Business Council, and you meet the 5 presidents, or the 4 presidents, the 1 prime minister annually. Russia has decreed that by 2020, 50% of all pharmaceuticals will be procured locally, regardless. And it's a decree. It doesn't matter what officials say or do. It's a decree. What I really liked about what the MEC said earlier is she said we've got to make sure that it happens, and we don't do this at the expense of growing other economies. I think, put differently, we should be exporting products, not jobs. So I think that's the mantra that we like to use. So what my experience is, because this cuts across different ministries and different departments, is that a lot of the intention gets caught up in the regulations and the red tape. And so maybe a way forward would be to look at 100 strategic pharmaceutical products in South Africa, and to remove those 100 products out of the tendering system so they don't get caught up in the red tape. And there's an official in some obscure department who wants to stifle all of this can throw the rule book at you. Unlike President Putin, who says this is going to happen, end of the story, it happens. Okay, so to remove that that possibility of blocking something through some obscure regulation, let's rather look at a different system for those 100 products or molecules, and that system could be entering into a triple P with local producers on a long-term basis for those products. What it will also do is it will help the country immensely with the stockouts. Because stockouts, I don't want to get into that discussion because that's a whole long discussion on its own. It's multifactorial. But part of it has been because there's been a lack of consistency and predictability in the tendering process, where you could win a tender for 2 years and for literally 10 cents lose it 2 years later. And then a new supplier's got to come on board, and that's partly where the stockouts have come into play. So if we move into a triple P model for those 100 molecules or more, whatever the case is, you'll get that certainty and predictability, but you'll also start reversing the trade deficit. It will allow you also to do what the MEC was saying, which is allow you to look at regional and continental procurement, or manufacture for procurement in the continent. And then your economies of scale will go up. Economies of scale go up, you're starting to build export platforms, also help you bridge the trade deficit. So that's just a suggestion, I think, from our side, how we can move forward on this discussion. And just the last comment I want to make is we've been debating local procurement endlessly for many years. The regulations were changed 2011. And it's quite an indictment on both government and industry, so all of us, the whole of our society, in fact, that in the midst of all of that, we've had 4 years, the trade deficit has grown every year by 20%. Thanks.
Thank you so much for your question, Mr. Nicola. So clearly, action is what's missing here, which we need to implement. There's a question over there. If you please introduce yourself, sir.
Okay, thank you very much. My name is Dr. Daniel Nemachena, and I'm from the Orem Institute. My question is around the 1990 DIP process that the National Department has introduced. This is looking at operational managers at a facility level being able to plan for their own running of their facilities, like it's actually being termed a 3-feet approach. MEC, I would like to find out, how are we going to be able to capacitate our managers to do this? We know that most of the managers in the facilities are usually clinicians who are promoted into these managerial posts, and yet we know that management is a totally different science from being an excellent clinician, for example. How does the province look to address this gap? Thank you.
Thank you so much for your question, Dr. Nyachima. MEC, maybe if we first address the issues that were raised by the private sector participants and even some of the suggestions which come through from Mr. Nicolau. I think for me, what I can take away is there's clearly confidence that should be gained here because communication is taking place between both the public and private sector, and suggestions are clearly being exchanged. The key issue being implementation.
I think first let me start with the infrastructure ideas. I think the point being made about infrastructure, PPP, Gauteng needs about 10 more district hospitals, besides renovating Hillbrow, as well as Kailami Hospital, Lodium and all of that. But we just need 10 new district hospital because the population has grown, the disease profile has changed and all of that, and we need to build those facilities cheaper in a much more cost-effective, on time, on scale, within budget. So, and we do not have money in the next whatever 3-4 years or 5 years at least. Our budget is decreasing, and my view is that we have to really look at how else do we deliver this infrastructure. We are exploring different mechanisms, working with our colleagues in DID, but largely agendas led by ourselves as to what do we do with this greater need in our community to build this infrastructure. So the role of the private sector for me is important. We're also looking at the Nkosi Albert Luthuli experience post 20 years down the line. We cannot say that what was done in Nkosi Albert Luthuli was wrong without looking at what are the lessons from it. Look at what are the lessons from Nkosi Albert Luthuli, what can we improve which did not go right, and so that we can, our people deserve better. And that's what we really should drive. We've built 2 beautiful health facilities in Zola, Jabulani, which is Begimlangini now. It's very beautiful. And in Natalspruit, which we are officially opening or renaming tomorrow to Cele, Mukharan and Alphonse. Again, the important point here, we need to, not only should we have state-of-the-art facilities, but we need to have well-maintained health facilities. Hence, I spoke earlier about there shouldn't be any disruption of electricity. Hospital is a 24/7 hospital. You can't take someone to theater when you're not guaranteed of that the electricity is going to be there and all of that, because you're going to lose lives and we're going to get a lot of people suing us and all of that. Mm-hmm. So that's very important. I think the point you're making, which is very interesting for me, building infrastructure for curative care. The cities are building a lot of public gyms in the different parks. And we support that idea. That's why the community health workers are able to do this. Not only should we have the public gym, we need to get South Africans a mentality that just to walk 30 minutes a day, it makes sense in your life. To eat decently, to consume less alcohol. We've looked at, I chair the social cluster committee in cabinet of about 5-6 departments. It's incredible to see the amount of alcohol consumed by South Africans as compared to many countries in the world. And if you look at how obese people consume beer and all of that, it's something that must bother us. Our eating habits, our just conduct as human beings, how we live, the lifestyle we live and all of that must also talk to that, because most people who come to facilities, the lifestyle disease pattern that has changed in the past 30 years, it's because of the way we live. The chronic diseases that we have, we've got about 5 million people on chronic medication. Hypertension, chronic hypertension, diabetes, cardiac related, and of course you must add the HIV and AIDS and all of that. So it can't be correct. It just cannot be that you've got so many people who are taking medication because, and on all of that. So that's an important point. The curative thing, education is important, but people must exercise. Indeed, the public gyms are being built, but they must be used by the citizens. Second point on that's raised by Mr. Nicolau, I fully agree with what he's saying, and that's why, for me, the issues about health is important because we are a procurer. and consumer of the services. But DTI, from a strategic level of where the country is going, from a trade deficit point of view, and jobs creation and all of that, has an important role to play, including the economic development and all of that. Hence, that's why I spoke about the Premier, because if the Premier convenes all of us and guides us and marshals us to this, as he's trying to do, we will succeed. And I can assure you that Gauteng, what is being proposed here, will put it to good use and working and be led by our Premier. Yes, indeed, our managers that manage our facilities are largely health workers. At clinics, we take nurses, and hospitals, largely it is doctors. It is common sense now that we do not have a health management training in South Africa that is very comprehensive for all our whatever. We spend a week about late June in Lancaster, because Lancaster University works with NHS, and there's no CEO in the UK who takes leadership in any NHS hospital without having been trained in Lancaster. So we're looking into that, looking at online training, because it's expensive to send people there, and looking at all of that. But the best performing of our CEOs will be sending there. We're going to also partner with the CEOs and all of that. Also, vets and other universities that we are working with are also looking at the training program that is determined. We are looking at what exactly this management is all about, because we are managing crisis literally every day. There's no strategic leadership. People are not paying attention to finances. For instance, one of the doctor CEO was saying to me, MEC, why don't you outsource the running of the hospital? Let us, all what we must be interested in is the clinical service. I said, but that's what is wrong. Because as a CEO, you must be interested in how the boilers are working, the steam is working, the mortuary is working, the pharmacy is working, the radiology is working. That's your business, your core business, your finances of the hospital, how you're spending, how you're procuring. That should be your interest. You can't just see yourself. You're a manager now. You've decided to come out of the clinician environment. So manage the hospital in its entirety. If indeed you don't want to be a manager, then let's step aside. So that's the kind of thing. So the point you're making is correct. And our interest really is to train every manager up to the lowest level in the province, because it is in our best interest to have well-trained managers.
It's a pity we couldn't go further into it, but thank you so much for your time today, and a big thank you as well to our audience members for addressing their questions to the MEC, Ms. Qedani Mahlangu. Together with our audience, do be sure to join us again next time, as this conversation will continue offline. From myself and the team, it's goodbye for now.
This CNBC Africa special is brought to you by the Gauteng Department of Health.